Now, Mr. Hamid is not here. Did he send a video in to you to show just now? Perfect. So, Mr. Hamid is a surgeon in northeast of England, and he's got a presentation here on the management of iliac artery aneurysms.
Hello everyone, I'm Haytham Hamid. I'm a vascular surgeon at Sunderland Royal Hospital in the northeast of England. My presentation today is about management of isolated iliac artery aneurysms. Firstly, I would like to thank the BEC organizing committee for their kind invitation, and I am sorry I could not be there in person this year. I have no disclosures. Iliac aneurysms are commonly associated with aortic aneurysms, and they are considered part of that pathology. However, there is a rare entity where they present as either unilateral or bilateral isolated iliac aneurysms. The definition of iliac aneurysms in general depends on the diameter measurements. For common iliac arteries, a 15 mm diameter is classified as aneurysmal in females, while in males, this threshold is 18 mm. Additionally, internal iliac arteries are deemed aneurysmal when the diameter reaches 8 mm. In 2001, Mr. Reber, an academic researcher and surgeon from Bern in Switzerland, classified pelvic aneurysms based on their anatomical location. For instance, type 1 involves only common iliac artery, while type 4 affects the common iliac artery alongside its branches. The recent ESVS guidelines raised the threshold for repair from 3.5 to 4 cm, acknowledging that ruptures rarely occur below 5 cm. Recently, we managed to repair an internal iliac aneurysm with a diameter of 10.6 cm as demonstrated on this CT scan. Notably, the largest reported diameter in the literature is 14 cm. Preserving the pelvic circulation is crucial to prevent complications such as patoclaudication or ischemia of pelvic organs. Therefore, the ESVS guidelines recommended maintaining at least one functional internal iliac artery whenever possible. Considering this, the choice of repair largely depends on the operator preference and the institution expertise, ranging from open and endovascular to hybrid repair approaches. Nonetheless, on our systematic review towards the end of last year, we found out that 95% of those patients were treated by endovascular means. Until today, there has been no clear guidance to support the endovascular approach. Societies like CERSI published their standards of practice nearly 15 years ago to assess selection between stenting, embolization, or both. But these guidelines have not been updated since then. Similarly, there are other studies which were published in the same year, one of which by Nicholas Milas, which aimed to provide more detailed insight, including an assessment of the diameter and length of the landing zones. However, it proved too complex to follow. And due to the absence of this clear guidance, we adopted a localized approach to planning such cases. Our focus was preserving internal iliac perfusion whenever possible, alongside securing proximal sealing zone by attempting to confine interventions to the iliac arteries. This strategy aimed to maintain the IMA perfusion. Initially, we used more traditional approach of a standard EVAR with iliac bifurcating device, which had excellent patency with excellent freedom from reintervention and disabling symptoms. but needless to say, this is an expensive approach. There is some evidence from case series to support using standalone bifurcating devices, sometimes with kissing stents configuration, to try to bring the cost down. Their short and medium-term results are encouraging. Some of these stents are licensed to be used as a standalone for such purpose, like the iliac stent graft. Moreover, the fenestrated EVAR limbs, whether custom-made or physician-modified, have been showing comparable results to iliac branch devices. So, if you can preserve the whole internal iliac artery, embolizing one of the branches and stenting to the other one can provide reasonable alternative approach to avoid debilitating symptoms with good patency rates. But sometimes that cannot be possible at all, and the internal iliac artery must be excluded. In such circumstances, we try to limit our repair within the iliac system by only embolization, for example. Or sometimes you might need embolization in addition to covering internal iliac artery origin by either normal stent or EVAR limbs. The challenge arises when you need a diameter more than 16 millimeters for the proximal sealing zone. In such circumstances, we either go across the aortic bifurcation to deploy a flared limb to keep the big part of the limb in the proximal segment, or use a reverse limb deployment, like in this case, when the flared limb was taken out of the delivery system and advanced inside the sheath using a blunt dilator, and then deployed partially inside the sheath, then completely released once the position was confirmed. You can get very accurate positioning with this technique compared to the cross bifurcation access. On the other hand, such limited repair is more important in special circumstances, such as mycotic aneurysms, where they can be treated by vein-covered stents, which was pioneered by my colleague Mr. Overbeek, where mycotic aneurysms can be excluded successfully with the vein-covered stent without requiring major open intervention or extending the repair to the aorta. So in general, when I ask myself whether these classifications are still practical in our current practice, the answer is yes in these circumstances, but no on other circumstances like these. So in conclusion, ladies and gentlemen, there is a need for a new classification or staging to guide our approach. It should incorporate concepts of pelvic perfusion preservation by using different techniques, including limiting endovascular repair to the iliac systems. It is durable, it avoids compromising the IMA and the lumbar arteries, and it is cost effective. So our work in progress is the RSI staging, where the R stands for the Reber classification, then the S is for the proximal sealing zone, where we try to limit it as much as possible to the iliac system, and the I is the internal iliac perfusion, where you try to preserve as much as possible. Thank you so much, and I'm happy to take any questions either now or at the end of the session. Hello.
Haytham, are you there? I don't think he's here to answer any questions, is he? No, he's not here. Yeah. Has anyone got any questions for him? Although he's not here. I think he's really been trying to simplify when to treat these isolated iliac artery aneurysms, which I have not found very common, but they can present either in the common iliac, the external, or the internal. or a combination of them all, and it influences how you treat them. Have you seen many?
No,
No.
fortunately. I have seen that when you have a AAA.
Of course, but that's not an isolated one.
More often to see it if
Yeah.
you have a aorta aneurysm, and that you have one or maybe both iliacs
Yeah.
taken to.
The iliac artery aneurysms that I've personally seen of the internal iliac artery are often occluded on their own. They don't need any treatment at all. Anyway, the next presentation.